glad to be able to join you guys today, particularly this way, because we're used to being together in 3D, but being together this way still works. And there's been a lot of conversation over the last few months about social distancing, and I like what some people have said with that what we need to remember is we need to maintain physical distance, but social connection. And we can be very grateful for platforms like this that allow us to continue to be connected, even though we're physically separated or physically distant from each other. So I'm really excited to be able to share this time with you guys. And I tend to be a fairly informal person and speaker. So what we are going to do is, in the interest of kind of being efficient with this platform, I'm just going to give you a little presentation, maybe 15 minutes or so, of some information that I think might be of interest, mostly related to COVID and how it impacts the world we live in and how it might impact your ability to seek or obtain care for spasmodic dysphonia. And then at the end, as Kim mentioned, hopefully you guys will chime in with some questions by way of the chat function. And then at the end, we can open it back up so it's a little bit more conversational and maybe address some questions at the end. So I wanted to start off with some numbers. Now, I don't want this to get too far into the weeds, but I want to at least give you guys some current statistics on where we are with COVID and give you a little bit of perspective on what that looks like in the history of the world without going too far into it. So let's back up the clock for just a second. 1918, there was a pandemic of the H1N1 influenza A that got nicknamed the Spanish flu. That pandemic started in the spring of 1918 and lapped over into 1919. The interesting thing was it dovetailed onto the end of World War I, and a lot of the news services were censored because of the war. And so the reason it became known as the Spanish flu is because Spain was neutral and therefore was reporting on the flu outbreak more than other countries. So the rest of the world assumed that it was happening only in Spain. But the truth of the matter is, more American servicemen died of the flu in Europe than they died in combat. And the other interesting fact is that after Armistice Day, the American military returned to the United States, and there was a second wave of flu in the United States related to the transmission from the military back to the mainland of America. So altogether, it's estimated that there were approximately 500 million cases of Spanish flu, H1N1, in the world in that time frame, 1918 to 19, and about 50 million deaths. So overall, that's a mortality rate of approximately 10%. That's a big number. 1 in 10 people succumbing to an infectious disease. And it's estimated that approximately 1/3 of the people in the world were infected with that virus at the time. Of course, modern medicine was not what it is now. So what did they do at that time to manage it? Social distancing. They closed movie theaters, they closed large venues, people wore masks, people were physically separated. It's oddly familiar to the things that we're dealing with today. So if we take that as historical, let's now look at where we are today. So as of earlier this week, the World Health Organization recorded roughly 7.5 million cases of SARS-CoV-2, or the virus that causes COVID-19. So 7.5 million cases in the world compared to 500 million of the original Spanish flu. And there's approximately a 5.6% mortality rate so far with COVID-19. So although we are climbing and undoubtedly we'll see more infected patients and people over the course of the next months or year, the mortality rate, in fact, is quite a bit less than the Spanish flu was in 1918. In the United States, as of yesterday, there were just over 2 million cases and a mortality rate of about 5.5%, with the exception of New York City, which actually does have a mortality rate of approximately 10%. So in New York City, which has been the hardest hit of any area in our country, the mortality is high. In the state of Florida, we have about 67,500 cases, and our mortality rate in the state of Florida is running about 4%. So that's where we are, snapshot as of this moment. Now, there are some important things that we need to think about. You know, we've heard a lot about flattening the curve. So what I want to do is go through some of the things that our government authorities are doing with regard to managing this outbreak and the pandemic. So at this point, I'm going to go to some websites that I wanted to share with you guys that will hopefully provide some useful information. The first one is sponsored by the Florida Governor's Office, Governor DeSantis, and what I wanted to specifically focus on is the COVID-19 information. So hopefully you guys can follow me as I go through these websites, just in case you're interested. So this is flgov.com, and this is an update on COVID-19. Toward the top of this page, we have the ability to go into Governor DeSantis' plan for Florida recovery. And in it, as you guys probably are aware, there's several phases. Phase 1, if you follow my cursor, was the original first part of our recovery plan that took effect May 4th. And I want to look at phase 2, which is where we are now, took effect on June the 5th. We have restaurants opening at 50% capacity. We have bars and pubs at 50%. We have gyms at full capacity, retail at full capacity with social distancing. I won't go through every one of these, but they are here for your reference and I think might be of interest. So you sort of see where we are. There's a lot of information that is passed around, but this is the source that you need to look at. Hospitals may continue elective surgeries, assuming they have adequate personal protective equipment. And this is important. All hospitals are required to test individuals for COVID-19 before being discharged, but also, it doesn't mention this, COVID-19 testing is required prior to any elective surgery. So we are following those guidelines at all of the facilities where we operate. So that is the current posture of the state of Florida. Things are opening up. You might be interested to know that there is a hospital capacity dashboard available on this website, and it goes very specifically by county, and you can even look at the number of ICU beds available if you wish. So just as a snapshot, Hillsborough County has about 3,000 beds available in total, of which 940 are currently open. So Hillsborough County is right at the moment able to offer about 22% of its capacity for patients to be brought in. I won't go through a lot of the detail, but there's a tremendous amount of information available on that site just to give you an idea about what our capacity looks like as a healthcare system. I want to now look at something that is cause for our attention. This is a website sponsored by the New York Times, which has been doing some very good tracking of the statistics of COVID, not only for the nation, but for individual states. This is the one that got my attention and should get all of our attention. This is new cases reported by day in Florida. And it starts in March and carries through to June. And the concern is at the end of this graph, as we're starting to relax on our social distancing and getting people back to work and life, there's a pretty significant uptick in new cases being reported. Not all that surprising, but very important for us to take note about. Now, fortunately, the new deaths are not tracking in the same way. So mortality has not really shifted, but we're starting to see more new cases reported. This is something that is cause for our attention because this virus has not gone away and is not tracking to disappear anytime soon. So we definitely need to continue to be careful about our behavior and our posture with regard to the virus. Now, I'm going to take you next to the CDC, the Centers for Disease Control. This is another site that has very, very good information about not only the current state of the virus and the pandemic, but also guidelines for all of us to follow in our daily lives. So this is their homepage, and as we track down, we find a section called Outbreaks, and there's information available about the coronavirus in that area. So this is a whole section on where we are with coronavirus, COVID-19, and how we can posture ourselves not only to protect ourselves, but what to do if we get sick. And as we go down onto that page a little bit, we find a key resource called Guidance. And under Guidance, there are a number of documents that specifically address various groups. Some of these are directed to hospital facilities or medical facilities. But as you track down, there was one that particularly I thought would be interesting to look at. It is called Running Essential Errands. So this is for community consumption. This is information about how practically to reduce your risk and to protect your fellow members of society as we're dealing with this time. And again, I'm not going to go through this in huge detail, except to point it out to you that it's here. But there are a few things that I think were helpful. First of all, what do you need to know? Stay home if you're sick. Use online services when available, which we are doing today. Wear a cloth face covering when running errands. Use social distancing, which means 6 feet away from others. Use hand sanitizer after leaving stores, and wash your hands with soap and water for at least 20 seconds when you get home. Now you'll notice that this does not say, hole up in your house and don't come out, but it is very, very important for us to be aware of the fact that community spread of this virus is now becoming much more common. Originally, when the pandemic was first starting, we saw a lot of transmission within long-term care facilities or in healthcare systems, but community spread is becoming much more common now as the virus makes its way through our society. So taking these precautions to be careful to reduce your own risk and risk to others is very, very important. And this site I thought was also handy because it talks about some very specific scenarios. Grocery shopping, go down a bit further, they talk about using curbside pickup, hand sanitizer, etc., deliveries and takeout, use online services when available, accept deliveries without in-person contact, which most facilities are making available. Banking, here's some information about how to deal with banking transactions safely. Getting gas, very practical. I like this site. So I just wanted to at least point this out to you guys, that it's a very handy resource. And if you haven't taken the time to look through the CDC's website, I would recommend you to do that. It's got a ton of information that is pretty accessible. Okay, last thing I wanted to do online is give you some information from the American Academy of Otolaryngology, specifically regarding how are we posturing as healthcare providers in the context of the pandemic. Just to give you a little bit of background, otolaryngology has been identified as a particularly high-risk specialty in the context of this virus pandemic. Kind of makes sense because the coronavirus resides in high concentration in the nasal passages, the nasopharynx, and the pharynx, the posterior pharynx, the throat. So any procedure that potentially can aerosolize particles from those areas is a risk, not only to the healthcare provider, but to other individuals, caregivers, and so forth who may be associated with a patient who is positive. One of the things that kind of got our attention as a specialty was a story that came out of Wuhan, China, early on when this virus was just being recognized. There was a surgical case involving a transnasal approach to a pituitary tumor, which is a tumor located up and behind the sinus cavities. And it involves approaching the tumor through the nose and then using a drill to open the bone around the base of the skull to enter the cavity where the tumor is located. Unfortunately, the patient was involved, that was involved in that surgery had COVID-19, and the care team was not aware of it. There was an otolaryngologist involved, there was a neurosurgeon involved, and there were a total of 14 people in the operating room. Every single one of them converted positive to COVID-19, and the otolaryngologist died. So naturally, this got the attention of the world community of otolaryngology. And so the American Academy of Otolaryngology has been right on the front edge of precautionary statements and advice to providers to ensure the safety of not only the providers and the care team, but also the patients. So the American Academy of Otolaryngology's website, again, has a lot of information. Much of it is directed really toward physicians, but this that I'm showing you today is open to the public. So if you're interested, you can review this for your own information. But in particular, there's some advice about providing care for spasmodic dysphonia that I wanted to share with you guys. So we're going to go to the Coronavirus Disease 2019 resources on this page, and we will drop down just a little bit, and you see the first segment here is guidance for return to practice for otolaryngology head and neck surgery. As you guys are probably aware, otolaryngology, like all other surgical specialties, stopped essentially completely in the middle of March. Our caseload in the operating room went from busy to zero in about 1 week. And it took about 5 or 6 weeks before we and the hospitals were willing to return to surgical care. And that actually included non-essential office procedures like laryngoscopies and things of that sort. In our particular office, in our practice, we never stopped offering Botox injections, which I'll address in a couple of minutes, but many places did. And so I expect some of you were finding it difficult to get injections during this time. That should be pretty well opened up again by now, but I'll give you some insight on why that was a problem. So there are two parts to this guidance for return to practice in otolaryngology. The second part is what I want to focus on, part 2, which was released May 15th. This you will find, I think, directly pertinent. This is a PDF document that I'm showing you, and again, not doing the whole thing, it's many pages long, but I wanted to point out a couple of things. First of all, within this document, the Academy designated procedures or interventions at various levels of critical nature. So first was emergent, second is urgent, third is time sensitive, last is routine. So in terms of priority, that's the way the Academy divided things up in order to stratify recommendations for care. So I'm going to scroll down here a little bit, and what you find is that we're looking at subspecialty specific considerations. So this document addresses various areas: allergy, head and neck surgery, and we now find that we get to laryngology. This is where we live, all of you and me. What we find is that under the laryngology heading, there are a number of specific procedures divided up into this stratified system between emergent, urgent, time-sensitive, and routine. So the question is, where do we all live? And you'll notice that spasmodic dysphonia is specifically highlighted under time sensitive. That's the category of urgency assigned to spasmodic dysphonia and dealing with transcervical Botox injections. Now, the reason that that's considered time sensitive is because, as you all know, not only is your quality of life dependent on your ability to communicate, but in fact, so is your safety. And particularly in a situation where we're dealing with this global pandemic, to be unable to communicate or uncomfortable communicating, particularly over electronic interfaces, becomes a significant issue. And so it's a priority to ensure your ability to continue to function. I think all would agree that although these are critical issues, they are not urgent or emergent in the same way that an airway obstruction or a cancer might be, but it's still a significant issue that needs to be made available as an essential service. So in that context, we take appropriate precautions in the office setting to ensure that we are limiting risk for patients who are coming in for services, but we do continue to offer these services for patients who need them with Botox injections. So what does it look like if you come to the office? I'm going to give you our routine, which is in line with the American Academy of Otolaryngology's recommendations and the CDC, just so you understand how the office is working. First of all, we are open. We never closed throughout the pandemic, although we cut back our hours, and some offices we had rotating closures and things like that. But we never closed completely because we are an essential service. If you come for care today, we have limited waiting room space with chairs that are separated for social distancing. And we generally are asking patients to either wait briefly in the waiting room area before they're brought into the back office, or in some cases to wait in their car. We're not generally allowing visitors to come in with patients for safety, both for the patients and for the visitors. So visitors are asked to wait in the car as a general rule. We have a series of questions that we're asking when patients come into the office. Typical things that you've all gotten used to. Have you had fever? Have you traveled? Have you been exposed to anyone with illness? Have you had cough, shortness of breath, change in sense of smell, any GI disturbances, anything that might indicate early signs of COVID-19 infection? Having passed all those screens, patients are brought into the back office where our medical assistants are wearing masks. We do perform vital signs now. We weren't doing even that for a while in the interest of protecting staff, but vital signs are taken. And our transcervical Botox injections are essentially the same as they've ever been. I personally am wearing a mask throughout the day, and patients may wear a mask or not. We're not strict about that for most people having Botox injections. Although if there's a high risk, or if you have a tendency to cough during your injection, we may ask you to keep the mask on. But Botox is delivered as always, no different in the procedure, how we're actually doing the injection. But the office environment certainly looks and feels a little bit different and a little bit more restricted. So that's kind of our status as we are right this minute. I'm going to stop screen sharing, which I think I just did. And Kim, if you're on the call, I think we can go ahead and address any questions if anyone would like to chime in.
Sure, Dr. Vincent. Thank you so much for that great presentation and that overview of the situation that we're all currently experiencing. Okay, the first question is, I continue to receive Botox injections on a 3 to 5 month basis. Invariably, the first 2 to 6 weeks, my voice is barely a whisper. I realize that the strength and the amounts have been varying until the sweet spot is reached. Sometimes the administering physician pokes around several times, seeming looking for the right spot. Is that normal? And also, is there any new developments in treatment modality to lessen the voice downtime?
Okay, good questions. So everyone probably who has had injections for spasmodic dysphonia is familiar with the sort of, how should I call it, the routine roller coaster. So after an injection, patients typically experience some weakening of the voice, breathiness, or raspy quality or high-pitched voice that may last anywhere from a few days to a couple of weeks. And then after that, the effect begins to settle in, and patients then generally have better voicing for hopefully many weeks or sometimes months. As a general rule, the length of time that the patient is breathy or raspy is proportional to the dose, as is the duration of the benefit. So if we increase the dose, there may be a longer span of time where the voice is breathy, but there also hopefully would be a longer span of time where the voice is good. Conversely, if we reduce the dose, we probably are going to shorten both of those parameters. So we may shorten the duration of hoarseness or breathiness, but the duration of the benefit would be less. So the whole thing about, I always say it's like an art and a science mixed together, because there's certainly science involved in Botox injections, but there also is a certain amount of trial and error. And so anybody that's been to see me knows that the first thing we do is talk about how the last injection worked. We talk about the side effects, we talk about the benefit, how long did it last, and all of that, because it's important to try to figure out what the optimal dose and optimal interval might be. As far as the placement of the injection and identifying the right spot, most physicians use EMG to find the optimal muscle activity in which to inject the Botox. And sometimes that's a little tricky, and some people's anatomy is harder than others. So the fact that it might take I've forgotten the description, poking and prodding, maybe something like that, that there may be some searching that goes on to find the right spot. That definitely happens, and it's not necessarily physician dependent. It may be anatomy or other things that are involved. A lot of times positioning the patient makes a huge difference to make sure the neck is extended well in order to get access. That sometimes makes a big difference. So there may be some things that could be adjusted to make that experience easier.
Wonderful, thank you. So next question, we actually go back to COVID. What is your thought about testing for antibodies as well as current COVID infection? And if so, is it being offered free? I would assume for the state of Florida.
The last part, I'm not sure about the answer to that, whether it's being offered free or not. I suspect some of these websites we just looked at might have some of that information, or the Florida Department of Health might be a better resource for the question about cost. As far as the test itself, there basically are two tests that we hear about a lot. One is the swab. That is a nasal swab done from the very back of the nose, from the nasopharynx, for the most effective sampling. And that is called a PCR test, which stands for polymerized chain reaction. And the idea is that test is looking for virus particles. So it actually looks for the proteins that are involved in the construction of the virus itself. So that is a test for the presence of virus. The other test, which is the antibody test, is a blood test, and that is designed to identify circulating antibodies that are your immune system's reaction to the virus. So if you're talking about an acute situation where a patient is acutely ill and we're trying to determine if the illness is due to corona, the best test is the swab. When that initially was available, the turnaround time was extremely slow. I know we had some employees actually tested early on, and it took over 2 weeks to get the results back. But that has been improved upon greatly, so we actually can get a turnaround of even down to a few hours in the hospital setting. But as an outpatient, typically about 24 hours. So that'll tell us whether the virus is present. The antibody test tells us whether the patient had exposure to the virus, but it's not a test for acute illness. So it's more an assessment of a patient's immunity potentially to the virus. Now there's a whole slew of questions that come up about false positives, false negatives, whether the antibody actually indicates immunity. What do we do with a patient who has recovered from corona and still tests positive on nasal swab, because that can happen. So there are some gray areas around these tests, but for the most part, the nasal swab is for the acute scenario and the antibody is for the after effect of an infection.
Great, thank you. Next question, does weather affect spasmodic dysphonia? I get regular Botox every 3 to 4 months. I recently moved from New Jersey to Florida, and I find my breathing and SD symptoms to be worse.
I would say probably that's more related to environmental factors other than something directly affecting the SD. So SD is, as you all are aware, is a neurologic condition. It is abnormal control of muscle movement that causes the spasms and the symptoms. But patients with SD are not immune to other things that can affect voice function, such as allergy, postnasal drip, sinus infections, reflux, all the rest. So I would assume that probably a person who's relocated from one state to another is experiencing environmental factors that may be adding to the SD symptoms.
Great, thank you. And then is spasmodic dysphonia related to Parkinson's disease?
Good question. They definitely are cousins, but they're not closely related. A lot of people wonder if they present with symptoms of SD, are they going to develop other neurologic problems, Parkinson's or tremors or other things? And the answer to that is spasmodic dysphonia is defined as a focal, that's F-O-C-A-L, dystonia. So from a neurologic perspective, it's a separately identifiable condition that does not, by definition, involve other movement disorders. So if a patient truly has spasmodic dysphonia, there's not a risk of developing other neurologic conditions along with it. Now, the sometimes complicated part is that some patients with other neurologic conditions, like Parkinsonism, can present with vocal symptoms that are very similar to spasmodic dysphonia. So there may be a sort of a clinical crossover between the two conditions, but not an actual sort of cross-contamination, if you will, between one condition and the other.
Great, thank you. So now we're moving into a little bit about other treatments. So are there other procedures for spasmodic dysphonia other than Botox? For example, vocal cord medialization.
That's the never-ending question. We all would love to have something that would fix this thing and make it possible to function. So we know that spasmodic dysphonia has been around for a long time, so has Botox. The first Botox was introduced for this condition in the late 70s, early 80s by Bren and Blitzer. They were the ones that really got this started. And it has remained the treatment of choice. It is effective for dealing with the symptoms, but obviously has its own sets of inconveniences, particularly if you stop reacting to it and that sort of thing. So the search is always on for other ways to treat the condition. As it stands right now, particularly if you think about surgical options, there are some surgical procedures that are talked about and performed for SD symptoms. But at the end of the day, we can't treat a neurologic condition with surgery. So the analogy I always give is sciatic nerve problems. So has anyone dealt with sciatica? Probably a few have. Sciatica is a condition in which the nerve in the lower spine is pinched and it causes symptoms in the leg. So the analogy would be if you have sciatic nerve problems and you operate on your leg, you're really not going to fix anything. The problem is coming from pinched nerves in the back. So the analogy would be with spasmodic dysphonia, if we have nerve symptoms that are manifest in the voice, but the problem is actually caused by incorrect regulation of those nerve signals from the brain, and if we operate on the voice box, we're operating on the symptom, not the cause. Now, all that to say, there are some interesting potential surgeries. The one that's gotten the most traction, I think, is the selective denervation reinnervation procedure that Dr. Burke has touted in California. And it has the potential to reduce symptoms some, but it essentially replaces a spasm with a paralysis. So the bottom line is surgical treatment is not very predictable or reliable for spasmodic dysphonia. So most surgeons are kind of shying away from that sort of approach.
Okay. And then next question, is there a connection between spasmodic dysphonia and oromandibular dystonia?
Oh, for sure. Yeah, oromandibular dystonia is also a focal dystonia, but a little bit more regional. So in oromandibular dystonia, the jaw and often the tongue and the floor of mouth are involved in spasms, and patients very frequently have vocal symptoms associated with that. The treatment most of the time is still Botox, but it may require Botox injections not only in the larynx, but also in the muscles of the, it's called the muscles of mastication, the muscles that are involved in jaw movement. A different scope of care, but Botox is still the mainstay of treatment.
Okay, and kind of following up on that, is having a focal dystonia related to a secondary dystonia like a movement disorder called chorea movement?
No, the short answer is not really. Choreiform movements are more global neurologic abnormalities that involve uncontrolled movement, but it's not really spasmodic, it's just more kinetic. So limbs typically are mobile. Patients, if you see a person with a choreiform disorder, it might look like they're just having a hard time sitting still. So they tend to be more global in nature. So not a direct relationship, but certainly there can be some crossover in symptoms.
Okay, and another, going back to the treatment side of this, can you educate us a little on fillers for vocal cords? How do they work? Is it effective? How long does it last? And maybe what forms of SD could it be used for?
Sure. So fillers are basically another way to perform what's called medialization. You may have heard of a procedure called thyroplasty, where implants are placed under the vocal cord to move them closer to the center. Fillers are basically doing the same thing, but they are injectable. They're sort of like gel, about the consistency of toothpaste. And those are injected into the vocal cord muscle, same muscle that we would inject Botox into, with the intent of literally moving a vocal cord closer to the center. So we typically use fillers like that for patients who have vocal cord paralysis as opposed to vocal cord spasm. The one potential exception to that is if a patient has AB spasmodic dysphonia. In other words, the disorder in which the vocal cord muscles are pulled apart during speaking. That's the less common variant of spasmodic dysphonia. Most of the time, it's the muscles pulling the cords together that are in spasm. That's the AD version. But in, excuse me, sorry, in abductor spasmodic dysphonia, sometimes it is helpful to get the cords closer together to reduce the gap, but we often still have to deal with the spasm. So I've done cases in the past on occasion where we'll do an injection with a filler and an injection with Botox into the posterior cricoarytenoid muscle at the same time, with the idea of trying to get those cords closer together and prevent some of that separation that can happen with the abductor spasm.
Right, thank you. And then circling back to COVID-19, does COVID-19 always affect the entire body, or can it be localized, for example, to the sinus or upper airways?
Interesting question. Pardon me. So COVID-19, like influenza A or any viral illness, is by definition systemic. So when you are infected with COVID-19, it will affect your whole body. Now, you can have symptoms in different parts of the body. So the typical symptoms that patients complain about with COVID-19 are respiratory. So people talk about difficulty breathing, cough is common. Loss of the sense of smell is one of the early symptoms that was not recognized until a little bit into the pandemic, but it's now something that we routinely screen for. People also talk about alterations of the sense of taste. But the short answer is a systemic virus like COVID-19 is likely to cause symptoms in many parts of the body, as opposed to the common cold, like a rhinovirus, tends to, even though it's still a systemic infection, it tends to only affect the upper airways. It causes nasal congestion, runny nose, and all of that. But COVID-19 is more likely to cause generalized symptoms.
And a follow-up question on COVID-19. Are your patients required to have COVID testing prior to a Botox injection?
So that is something that we have debated about somewhat, but we have not required that for Botox injections, nor have we required it for routine, low-risk office procedures like laryngoscopies or nasal endoscopies, where we are not manipulating mucous membranes. So to make the distinction, if you have a fiber optic laryngoscopy in the office, which I'm sure many of you have had, if not all of you, that procedure involves passing a scope through the nose into the back of the throat to look at the voice box, but we don't do anything. We're just looking. Contrast that to sinus surgery. If we're doing sinus surgery where we put a scope into the nose and remove polyps or open sinuses or something like that, that's going to involve violating mucous membranes, in those situations we do require COVID testing prior to the procedure, even if it's done in the office. And the other thing that we've been doing, and this even for routine laryngoscopies, is that in patients who are not allergic to iodine, we are prepping the nose and having the patients gargle and rinse with an iodine solution. This is an elemental iodine solution that actually we've borrowed from the dentists. It's a solution, it's sort of like betadine, but it has a much, much higher bioavailability of the iodine ion. So it's more effective as an antiseptic and kills both bacteria and viruses. So we're doing a nasal and oral prep prior to even a routine laryngoscopy in order to reduce risk. And so, in a short answer to your question, we don't require COVID testing prior to Botox because we are, number one, not entering a cavity that has mucous membranes in it. And number two, we're not likely to encounter aerosolization unless a patient is coughing or something like that.